Now, if I talk about the indications, presently it is actually the surgery of choice for the all types of adulthood as well as the childhood cataract. Unless and until it is contraindicated, we are doing ECC. So, that will be called as ECCE. This is called as ECCE with PCIOL implantation. So, what we are doing nowadays is ECCE with the PCIOL implantation. Instead, you can remember that there was only one indication of ICCE, that was subluxated and dislocated lens. So, that will become a contraindication of ECCE, that is the only indication of ICCE. Because you know, if the zonules are already weak, I won't be able to preserve the posterior capsule and I won't be able to do the PCIOL implantation. Now, coming to the types of the extracapsular cataract extraction. So, these can be of three types. The conventional ECC, that you are doing ECC with the PCIOL, then we have small incision cataract surgery, and then we have the phaco emulsification. Now, you will say, what is the difference between the three? The conventional extracapsular cataract surgery is a very open incision surgery. There you are giving an incision which is very large, that is about 7 to 8 mm. While in the cases of ICCE, we were using the incision that is 10 to 12 mm. 10 to 12 mm. Here in the conventional ECCE, we are using the incision that is smaller than ICCE, 7 to 8 mm, and along with this I am giving the interrupted sutures. I am giving the interrupted sutures here. I will be talking that in detail. Now, small incision cataract surgery. Now, nowadays we want to do small incision surgery or the sutureless surgeries. So, this small incision I am giving about 5.5 to 7 mm incision, but this is manual. So, when you are doing the small incision surgery manually, this is called as SICS, when I am doing this small incision surgery with the help of a phaco machine. When you are doing it with the help of a phaco machine, then it is called as phaco emulsification using the incision of 3 to 3.5 mm. So, these incision size are again important. ICC 10 to 12 mm, then here we have 7 to 8 mm, this is your 5.5 to 7 mm, and here we have 3 to 3.5 mm. You will also see that there are two important kinds of phaco emulsification which are slightly different. They are called as micro incision technique, and then we have what you called as phaco knit. Then we have phaco knit, micro incision technique and phaco knit. Micro incision means when you are using even the smaller incision less than 2 mm, and phaco knit, what is this? This is your needle incision technique. This is the knit, actually needle incision technique. This is using even less than 1 mm, because you know phaco machine has a titanium needle. It has a titanium needle, and with the help of that titanium needle whose diameter is 1 mm, I can do this needle incision technique. I can take only the needle inside and I can do the cataract surgery even by 1 mm. So, 1 mm, 2 mm and 3 mm are phaco, then 5.5 to 7 is your SICS, and 7 to 8 is your ECCE, and 10 to 12 is your IC. Now, I will be telling you first the conventional ECCE steps, because this is the basic surgery that we are doing. So, you should know these basic steps as a beginner also. If you are starting in your college, when the examiners your seniors or the consultants will give you the case, so they will be giving you the simple steps from this surgery. Nobody is offered the total cataract surgery as a whole, so you are first doing the simple steps. So, let us see what is the first step that you are doing. So first thing is that you have to prepare the area of surgery where the surgery has to be done. So if this is the eye, okay, here, and you know this is the forehead. This is the forehead here, because you know you have to actually see that you are standing on the head end of the patient. Okay, these are the eyelashes here, and I have to actually expose the area which has to be operated. So what I am doing, I am first passing the superior rectus bridle suture here. This superior rectus bridle suture has to be passed here. The reason is that when you are actually pulling the superior rectus bridle suture, you are getting a lot of area to work upon. So this is the first thing, and you have to be very, very careful, because you know these muscle bellies are very, very fragile. So if you are not able to do it once, if you are doing twice, thrice, then it can also be perforated. So this kind of needle is there. So you are giving this bridle suture, and then you are tying it back. Then the second important thing that you have to do, you have to actually suppose this is your cornea here, so you have to create a flap here, okay, because afterwards you have to make a entry into the anterior chamber. You have to go inside the anterior chamber, only then you are able to aspirate the lens. If you look at the section, how it is like, suppose this is your cornea here, and this is your iris. Okay, now we have already dilated, so let me make the dilated ones. So we have dilated, okay, like this. So here you have the lens. So basically I have to reach up till here, I have to make the AC entry. So for that I have done, and after this I have to make that partial thickness groove or gutter through which you have to go inside. And once you have made that gutter, then you have to make a corneoscleral section. So this is also called as corneoscleral incision. This is also called as the corneoscleral incision. So basically when I am talking about the size of the incision, so I am talking about this incision. So this incision will be 7 to 8 mm in cases of ECC. This incision will be 5.5 to 7 mm in cases of SICS, and this incision will be 3 to 3.5 in cases of faco emulsification, because the basic steps are more or less same. Okay, then what you are doing, as soon as you are making the corneoscleral section, you are making an incision, you know, you have made the AC entry, so aqueous humor will lose, and you know anterior chamber will tend to become flat. So when, in order to stop this from collapsing and to maintain that anterior chamber, we do the injection of this viscoelastic substance in the anterior chamber. So for that what we are doing, we are using the 2% methyl cellulose. Either we are using 2% methyl cellulose, or we are using 1% sodium hyaluronate. So you can remember these two names, because these are the most commonly used viscoelastic substances that are used in order to maintain that anterior chamber. And why it is so important to maintain the anterior chamber, because you know if anterior chamber is not maintained, if it is flattened, so obviously there will be a problem with the posterior surface. So if this posterior surface is hampered, endothelium will be damaged, and you know endothelium is the most vital layer of the cornea, that is responsible for maintaining the metabolic activities of the cornea and also for the transparency. So it is very, very important to actually protect this endothelium to maintain the transparency, because you know it contains the sodium potassium pump, and also it is the most vital layer, and also it is important for the metabolic activity. So for all that sort, the endothelium is the most important thing. Then what you are going next? Now once you have made the entry inside the anterior chamber, and you have also injected the viscoelastic, you have maintained the anterior chamber, now what you have to do? You have to remove the anterior capsule, because remember what was ECC? In the ECC I am removing the anterior capsule plus epithelium, plus I am removing the lens. Now in the lens I am removing the nucleus also and the cortex also. So all these things have to be removed. So if I look at the lens, it has got a very thin film of anterior capsule over it. So it is like this. So you have to remove this anterior capsule. When you remove this anterior capsule, actually you are not able to see it because it's a very very thin membrane. So you require the staining. You have to do the staining of this anterior capsule first. So this staining we are doing with the help of the trypan blue. So name of this dye is again very very important. You have to use this trypan blue dye, and then this will give you a blue color, what you call as typically the royal blue color will come, and then you are able to see it. So in that we are using the two techniques. Either we are using the can opener technique. So there are two things that we can do. Either we can do the can opener technique. I am giving a nick here, and then I am trying to pull it off. I am giving a nick here, and then I am trying to pull it off. This is your can opener technique. The second thing I can do is with the help of a bent needle like this. So I am giving a nick here, then I will bring it to the periphery, okay, and then I will keep on extending it in a circular fashion. This is called as the continuous curvilinear capsular axis or circular capsular axis. Both the things means the same, continuous curvilinear capsular axis. Axis means rent or the opening. It's a continuous opening in a circular fashion made in the anterior capsule. Now once you have removed this anterior capsule, what will be happened? You have removed this anterior capsule along with the epithelium. Now you are there with the lens. So first we have to do the delivery of this nucleus. So see this. So what we are doing, we are first removing the anterior capsule. Now once you have removed this anterior capsule, you have to do the nucleus delivery, then you have to aspirate the cortex. So what I have to do, I will have to enlarge the section now because I won't be able to remove the lens otherwise. What was the diameter of the lens? 9 to 10 mm. So obviously, so I have to now complete the corneoscleral section, I have to enlarge it. Okay, now once you have enlarged it, here comes the role of your irrigating solution, the role of the irrigating solution. So what you are going to do? First of all, tell me what is the best irrigating solution? Best irrigating solution is your basal salt solution with the glutathione. Basal salt solution with the glutathione you are using. Now what you are doing, we are doing first the hydrodissection. So you should know what is actually hydrodissection. So if you look at the instruments, there I have shown you Simcoe's irrigation aspiration cannula. So we are actually injecting that irrigating fluid between the capsule. So what we are doing actually, it is injected between your capsule and the cortex, so that we are trying to separate rest of the cortex, the posterior cortex from this, the posterior capsule from this cortex, because you know you have to leave this posterior capsule intact. Anterior capsule you have already teared off. Now I have to separate this cortex from this posterior capsule so that I can aspirate this cortex and I can leave that posterior capsule intact. So that is called as dissection with the help of a hydrating fluid. That is called as your hydrodissection that you are doing. Now sometimes what happens that there is dense nuclear sclerosis also, there is nuclear cataract also. So in that cases we require the hydrodelineation. We also require the hydrodelineation. Every case may not require the hydrodelineation, but every case require the hydrodissection. So this hydrodelineation actually separates the epi as well as endo, and epi and the endonucleus. So hydrodissection is actually separating the capsule from the cortex, and this is separating the epinucleus from the endonucleus, sometimes maybe nucleus from the cortex also. Okay, so we have loosened it out. Now once you have loosened it out, what you have to do? Now you have to remove that nucleus. Okay, now we have got different techniques by which you can remove this nucleus. One is your pressure and counter pressure method with the help of the lens hook. Again you have to look at the instruments, I have taken that separately. What you are doing it, you are giving the counter pressure here, so that it is coming towards this side, and with the help of the lens expressor, with the help of the lens expressor you are removing it out. Or you can also use your wire vectors. Wire vectors is something like this, in which you can hook your nucleus, and I told you in that video, instrument video, that there are two kind of wire vectors. One is irrigating, one is your plain one. So I can use this irrigating one also, which will again help me in more and more delineation of the nucleus, and I can remove that nucleus. Okay, now once you have removed the nucleus, what will be done? You will then aspirate the remaining cortical matter, because ultimately I have to make that area very, very clean, so that now I am left only with the posterior capsule, so that I can implant my IOL. So you start with the irrigation and aspiration of the cortical matter. Now once the irrigation and aspiration of the cortical matter is over, now is the time of your IOL implantation. Now one important thing at this step, don't open the IOL before this step. So IOL has to be sealed, it should be sealed at the time of the IOL entry, and just before you have to implant the IOL, you have to open that seal. It has to be sent with the other OT stuff last day evenings for the sterilization, and you cannot use it if the seal is broken, because you know we cannot take risk. Any chances of sepsis we cannot give, we cannot take any risk there. So once you have actually given the IOL, you have done the implantation of the IOL, then you have to do the closure of the incision. Now for the closure of the incision, what you are doing, suppose this is your corneoscleral incision, so we are giving radial interrupted sutures like this. So number of the sutures actually depends what is the size of the exact size of that incision, but yes, mostly we are giving, I think 3 are very, very less, 5 interrupted suture, 5 to 6 we are giving 5 to 6 interrupted sutures for the ECC. Now after you are doing this, you have to remove that viscoelastic back also, because we had injected that, okay, and then the conjunctival flap that you had made, that has to be reposited back. Now why I am saying reposited back and why I am not saying suturing back, because you know you don't need conjunctival suturing, you only need the corneal suturing. Cornea is avascular, will not heal by itself, but conjunctiva is highly vascular, so it will heal by itself, so not a problem. You will place the flap back, and then we are doing two things. First we give the subconj. Subconj is a subconjunctival injection that will be given to give the antibiotic also, steroid also, because you know infection is always a big risk in the cataract surgery also, and you have to give the steroids, because you know there is a lot of trauma doing the surgery, especially those people who are diabetic or having low immunity, or the young surgeons. So you have to give the steroids for combating the inflammation, and ultimately put the antibiotic eye ointment inside the eye, and you have to patch the eye at least for 24 hours. So that is the total steps that you are doing for the ECC. Now I will be talking about the manual SICS. Now some of the basic steps will be same here, like I will be giving the superior rectus bridle suture, same I will be using the Fondix blazed conjunctival flap, okay. Then I have to maintain the hemostasis also. For this I use the dithermy, or I can use the electric or the thermal cautery. Electric or the thermal cautery we can use for this, because you know as soon as you give the conjunctival incision, there is a lot of bleeding from there, because conjunctiva is a vascular organ, and you know especially hemostasis is very, very important. Those people who are having hypertension, or who are having some heart diseases, or they can be even irregular bleeding, so you have to be very, very careful in all these conditions. Now there is something different in this SICS with respect to ECC. This is your small incision corneal cataract surgery, where you make a tunnel actually. So that is why I even remember today my consultant used to call it as TICS. This is tunnel incision cataract surgery. So basically here we are making a deeper tunnel, corneoscleral tunnel, and the incision size, as I told you, is 5.5 to 7 or 7.5 mm, okay. But if you see the size of the tunnel, I think when you are getting into the learning of the surgeries, making this tunnel is the most challenging aspect there, and this is about 1 to 1.5 mm. Then now, because the incision is smaller here, so it sometimes is not possible to take the irrigation aspiration cannula also from the same incision, because we are not enlarging this incision afterwards. So what we are doing here, we are using the side port entry. Side port entry ke liye we are using a blade called as the side port blade. This instrument is recently being asked in the FMG exams, August 2020 also. This is asked in FMGE exam according to the memory based questions in 2020 here, and they had shown a blade something like this, which was having a very thin angle, that is your 15 degree, and they said that what is the name of this instrument which is used to make an entry into the anterior chamber. So that is called as a side port blade. Now once you are inside, again you have to do the anterior capsulotomy by the can opener technique or the circular curvilinear capsular access. Once you are inside it, you have to do same hydrodissection, hydrodelineation. Now what you are doing for the nuclear management, now this is somewhat different because the area that you are working in here is comparatively less, the incision size smaller. So what you are doing, first we can do the prolapse of this nucleus into the anterior chamber, and once it has come into the anterior chamber, then you have to take it out through that tunnel. Once the nucleus delivery is done, then same you have to do the aspiration of the cortex, you have to do the IOL implantation, you have to again remove your viscoelastic material, and you have to do the wound closure. Now wound closure may obviously it is a smaller incision, so you may be requiring the smaller. So here I can say that 3 to 5 sutures may be required here. This is also not completely sutureless, but yes, lesser size of the incision, lesser complications, lesser sutures. So a kind of faco, manual faco, or it is the poor men faco. I can say that basically this is a poor men faco, who are those people who want a good results, small incision surgery, cannot afford phaco. This is a very good option for them. Now finally we come to the phaco emulsification. So now I am taking right from the corneoscleral incision because you have already understood the basic steps. So the thing is that here the incision size is very small. I told you it is 3 to 3.5 mm. See, if they are using the word only phaco emulsification, go with 3 to 3.5 mm. If they are using the word micro incision, 2 mm, and phaconet 1 mm, this is the thing you have to follow. Then once you are inside, you have to give the anterior capsulotomy. Here we are basically using the continuous curvilinear capsular access only. We are not using the can opener technique here, and this is a question which they are asking many times, that which kind of capsulotomy, anterior capsulotomy is preferred for phaco. Then same, you have to do the hydrodissection or hydrodelineation if it is required. You have to do the nucleus delivery. You have to aspirate the normal the remaining cortical matter. You have to do the IOL implantation. You have to remove the viscoelastic material and the wound closure. Now this is basically a sutureless surgery. So this is the sutureless surgery, and we don't require the sutures, so that is a good point, and early rehabilitation can take place. Lesser number of complications are there here. Phaco emulsification, as you know, takes place by the phaco machine, titanium needle 1 mm, and what is the speed? 40,000 times to 60,000 times per second. Okay, the speed is that high. This is because of the piezoelectric crystal. So these are the questions that they can ask you in the viva. So what is the speed? Why it is taking place? Due to the piezoelectric crystal which is present in the probe. This is present in the probe. And what are the radiations they are using? They are using the ultrasonic waves. They are using the ultrasonic waves for this. So again, this is important here. Now let's see some of the techniques which are used for the childhood cataract surgery, because you know childhood cataract surgeries are somewhat different from the adults. So what we are using basically, one is your irrigation aspiration of the lens matter, and second is your lensectomy, and the third of course is that conventional ECCE with the PC IOL that we are doing in adults. I can do that also, but that is given preferably after 2 years of age. So what we are doing when we are doing this irrigation and aspiration of the lens matter, one possibility is that you are going through this conventional ECCE method, and the second is that you can go with your tunnel methods also, that is the same your SICS method or the faco aspiration techniques also you can do it. So what you are doing, let's see here step by step. So the initial 4 steps, that is what you were doing, the superior rectus bridle suture, or you were giving the incision, okay, all those things were same, conjunctival flap was made. Now up to the side port entry they are saying it is same. Once you have went inside, then one is your incision like this, then you are giving a side port entry, okay, so that we can do the irrigation aspiration. Now here the difference is, first of all, the capsular rexus that you are doing inside, that is larger, that is 5 mm. Then you are doing that irrigation and aspiration, and a very important thing, in cases of adults we were not doing any posterior capsular rexus, but here I am doing a posterior capsular rexus also, and that is 3 to 4 mm. So why I am doing this? This is called as primary posterior capsulotomy. This is the primary posterior capsulotomy which is done in children. Why? Because the risk of PCO, posterior capsular opacification, is very high in these patients. Whatever are the remaining cells, lens epithelial cells, these are called as LECs, lens epithelial cells, which are remaining from the anterior capsule, are highly dividing cells, and they are leading to proliferation. They are migrating to the posterior capsule, they are proliferating, leading to opacification, and it's very high chances. That is why we do not wait for the PCO to happen, and we already create this opening in the posterior capsule. Then what we are doing? We are also doing the anterior vitrectomy. I think this is again important, because anterior vitrectomy also we were not doing there. The reason is that there are very strong adhesions in cases of children between the posterior capsule of the lens and the vitreous. We are also having what you called as the V-girt ligament. So due to these reasons you have to do the vitrectomy also, in order to decrease the risk of the retinal detachment in future. So we are also doing this anterior vitrectomy. Then you are doing the implantation of the IOL. Now implantation of IOL is usually preferred after 2 years of age, and secondly what you are doing, you are giving the heparin coated IOLs or the fluorine coated IOLs in cases of children. So if you want to give, or you are having such a situation that you feel that you have to give the IOL, then give the heparin coated IOL or fluorine coated IOL, because you know in children the chances of the reaction or the chances of uveitis are very high, right? That is why we are doing this. And then again same thing, you are doing the removal of the viscoelastic substance and closing the wound. Now talking about the lensectomy. Okay, in lensectomy means what? So theoretically speaking, it is the most of the lens, including the anterior capsule, posterior capsule along with the anterior vitreous, is removed with the help of a vitreous cutter, intusion and suction machine. So basically what they are calling as lensectomy is the lensectomy with vitrectomy. lensectomy with vitrectomy. So in the previous option, what we were doing the lensectomy, we were leaving the posterior capsule and we were creating a hole in the center. But here what we are doing, we are aspirating whole of the lens with anterior capsule, posterior capsule, and some amount of anterior vitreous also we are removing, again to decrease the chances of the retinal detachment. So in cases of children, when we are doing this, we are doing it under the general anesthesia. I told you before also that in cases of children, we are using the general anesthesia because children will not be able to cooperate with you. Now, few words about the intraocular lens implantation. So, when you are doing the cataract extraction, what is created is your aphakia. So, aphakia is created and the treatment of choice for aphakia nowadays is your PCIOL implantation. PCIOL means the posterior chamber implantation. Now, in the posterior chamber, we can give it in the ciliary sulcus, or we can give it over the posterior capsule. So, it is this posterior capsule which is called as in the capsular bag, considered to be the ideal site. This is considered to be the ideal site for the IOL fixation. But otherwise, I can also give it in the anterior chamber. Right, we can have ACIOL, I can have the PCIOL. ACIOL means anterior chamber, PCIOL means posterior chamber. In the posterior chamber, I can have ciliary sulcus, I can have the posterior capsule. So, ACIOLs means you are giving in the anterior chamber, something like this. Can you see? These are placed in front of the iris, though they are not very popular. Okay, because there are a lot of complications that can take place, but they are actually supported in the angle of anterior chamber. That is why they are called as ACIOL. The advantage is that you can give it in both ICCE as well as ECCE, but the chances of complications, especially the bullous keratopathy, is very high. So you are not giving it. Even the chances of UGH syndrome. The chances of UGH syndrome are again very high. U for uveitis, G for glaucoma, and H for hyphema. So all these chances are more. That is why you are not giving them. When indicated, now if at all I want to use it, suppose I am having ICC done in my patient, or suppose there is a posterior capsular rupture. So again then I have to give this ACIOL. Which type I will be using? Kelman multiplex IOL. So you can remember one name, Kelman multiplex IOL is used there. Then we have also the iris supported IOLs or ciliary sulcus IOLs. They have got claws or loops or sutures holding the iris in the near the ciliary sulcus. So again here the chances of complications are very high, pigmentary dispersion from the iris and a lot of endothelium decompensation, so we are not using them. So what are the best? Best are your posterior chamber IOLs, and they are lying over the posterior capsule behind the iris, and they are considered to be the best ones. Now depending upon their materials or the material of which they are made, there can be rigid IOLs, there can be foldable IOLs, and there can be rollable IOLs. So this is again very commonly asked in the question. The rollable IOLs are made up of PMMA. The rigid IOLs are made up of PMMA. Rigid IOLs are called as rigid single piece IOLs. They are not flexible. So the rigid single piece IOLs are actually made up of PMMA. Then we have got the foldable IOLs. So foldable IOLs are mainly made up of acrylic, and the rollable IOLs are made up of hydrogel. Now do you know why I have not ticked hydrogel here? Because hydrogel is in the rollable also. So when it comes to hydrogel, you have to remember the rollable, so remember the HR, okay, while you have to remember the AF, that is foldable for acrylic. So we have got different designs of the IOL. Can you see here? This is your Kelman AC IOL, this is your iris claw lens, and this is a typical that we are using nowadays. Is this C-shaped IOL. This is the most popular one that we are using. So with this we have come up to the end of this session. I hope you must have been benefited with this. If you like the video, please do like the video, subscribe to the channel so that you get the latest notification of all the videos. Please do share the video also to those students, those people whom you feel that must be needing. I want, actually my honest wish is that I can help maximum of the people in this COVID times when they are not able to go to the wards and getting very less of the clinical exposure. Do let me know what are the other videos that you want me to make, and what is your feedback about this one. Keep on working hard, and I am always there for you. Thank you and happy ophthalmology.